Hello, everyone. Um, my name is Raji, and we are talking on the sexual differentiation of in sacroiliac joint kinematics. Um, I'm an engineer, same as my partner Jeremy Leisure, and we're both engineers at medical device development in San Francisco, and we have worked a lot in the development of treatments for the SI joint, as seen by the companies we consult with. However, our studies are typically not funded by external parties, and so they're all self-funded, just as a disclaimer. We're a team of four based out of San Francisco, and we develop a lot of quality biomechanical evidence for the SI joint. As we've all talked about before, we know that the SI joint is the largest axial joint in the human body, 2 out of 3 joints, and it has very small motions, but very powerful motions, as you have heard from Dr. Toyohara and Dr. Kurosawa as well. We understand that there's sexual dimorphism of the pelvis, but there's also sexual dimorphism of the sacroiliac joint. We also believe that form influences function, such that a change in morphology may change the way the joint behaves. And if that change in morphology differs between sexes, it also means that the male and female joint may behave differently. And part of our aims here was to really explore that and to really understand what does that look like. Just to set the a point for where we'll be going to, we took a review of the pictures from every biomechanical study that had been published since 2014. And what we saw is that they were all missing the sacrotuberous and sacrospinous ligaments. And this is a question that in Australia last year, I think it was Ingley, a partner of Dr. Sturson, asked about. And it led us to think and to really reflect back on the dissections we've done over the past going to 10, 15 years now. And one of the things that we noted and amongst ourselves, amongst our engineers, was that just anecdotally, that we found there to be a bit of a variation in the sacrotuberous and sacrospinous ligaments when we palpated them during dissections. So in one case out of about 50 joints which I have dissected, we had the sacrotuberous ligament ossified, but more frequently than not, we saw them to be pretty lax in about a third of the specimens that we dissected. So that means 2 out of 3 would be pretty tight, but 1 out of 3 would be really lax or loose. And in reflecting on that, it made us to think what could be the impact of a loose sacrotuberous, sacrospinous, and iliolumbar ligaments. For just to group them all together, we call them the secondary sacroiliac ligaments. So what would laxity involve? And so in our objectives and in thinking about that as its dysfunctional state, we wanted to characterize the motion properties of the intact and a dysfunctional sacroiliac joint. We talked about this in terms of the range of motion, the coupling of the motion. And what I mean by coupling is if we were applying a flexion load, would we see motion in axial rotation or in lateral bending? And we also wanted to understand the axis of rotation, and that would really influence the way we treat. And we'll talk a little bit more about that. But the comparisons we're putting forward are between the sexes, between the planes of motions, and between the directional pairs of motion. So for example, in the schematics shown here, if you look at the joints in green and red, the motions relative to those joints, we term them contra or ipsi motions, whereby ipsi axial is bending towards the joint anteriorly, and contra-axial is bending away from the joint anteriorly, but towards the joint posteriorly. And the same way, if lateral bending is bending towards the joint superiorly and bending away from it, would be contralateral bending. And we all know nutation and counter nutation as well. Our methodology, we had 24 specimens, so 12 asymptomatic. When I mean asymptomatic, I mean that really the sacrotuberous ligaments and all the ligaments were intact. We did not see any bridging of the SI joint, and 12 dysfunctional. In these cases, we had released the secondary ligaments of the joint, but the joint was still intact in terms of the joint space, no fusion of any of them yet. And we classified this function for us as being due to laxity or release of the secondary ligament. In our model, we did a single extent and applied spine bending motions to them between 0 and 7.5 Newton meters of torque, and in steps of 1.5 Newton meters as well. That's about 5 steps. We used optical tracking system, and we labeled points across the SI joint. If you look at the top right image, you see some black dots. Those are tags that we put around the joint to really trace out its extent. So we could track that and see calculate axes relative to those points of the joint. We measure the range of motion, the coupled motions as well, and the axis of rotation properties such as its alignment and its intersection with the joint. Our first results were interesting and really contrary to what had been published before. Previously, everyone said that nutation, counter nutation was the most mobile plane of the intact joint, but that's not what we saw when we had the secondary ligaments intact. What we actually saw was axial rotation was much more, or a bit more than the other planes of motion. So if you look at the blue trend lines, axial rotation sat at the top of an intact joint, while nutation and continuation was second, and lateral bending was third. But in a destabilized joint, as a dysfunctional joint, we saw that axial rotation or nutation, continuation actually spiked up to become more mobile than axial rotation. And this was in consensus with every study that had removed the secondary ligament of the joint. And in those studies, they did see that. And then we also thought about the clinical studies that have been done as well. But what we found out in the clinical studies was that the clinical studies only really measured these motions during applied flexion extension load, like rise to stand or walking or bending, but none ever tried a twist of the twisting motion. And you can imagine that if the rest of the spine, due to its facets, prevents axial motion, that motion needs to be transferred somewhere. And our thought is that that motion may be actually transferred to the SI joint as well. But just to move forward, we also found not too much of a difference in the intact male and female joint as long as the secondary ligaments were still intact. But when there was dysfunction, the female joint became hypermobile, but the male joint pretty much still stayed roughly the same. And so in a dysfunctional joint, I think one key takeaway here is there begins to be a very big difference in the mobility of the female versus the male joint. We also inspected the directions of motions in directional pairs. And in these cases, we're comparing between nutation, counter nutation, to see if there was more in one direction than the other, or IFC versus contra. The same trends also remained. Intact male and female were similar, but dysfunction led to an hypermobile female versus the male. We also then found a lot of asymmetry. And by asymmetry, we mean that we saw that counter nutation generated more motion than nutation. We may understand this because the resistance to nutation can be good for load bearing as well. At the same time, we saw more IPSI lateral bending than contralateral bending. And we finally saw that in a dysfunctional male joint, the male joint lost its asymmetry. So its total range of motion did not change, but its directional range of motion changed to become symmetric, whereby there was no more difference between nutation and counter nutation. It was pretty much equivalent. But in the female joint, it didn't lose asymmetry. It even became more asymmetric, whereby there was still very hypermobile. So the asymmetry remained, but it became really hypermobile in all directions, or specifically in nutation, counter nutation, and lateral bending. Axial rotation still pretty much stayed the same. It wasn't too influenced by dysfunction, except in the female joint where it became asymmetric as well. And contra-axial rotation, and when it became asymmetric, it was contra-axial rotation that became a lot more than axial rotation. And contra-axial rotation leads to expansion of the pelvic bowl, which we could understand could be necessary for childbirth. Finally, before we go through the take-home messages in this, we inspected the coupling of the motions. What were the other motions that were happening during our applied loads? So what we saw as a difference was that in the female joint especially, although it was also seen in the male joint, but not statistically significant, we saw that axial rotation was the biggest contributor to off-axis loads, such that during flexion extension, or nutation counter nutation, there was a lot more axial rotation added onto it. And during lateral bending, there was also a significant amount of axial rotation added onto it. Where we saw a difference between a intact and an intact and a dysfunctional joint was also in axial rotation as the applied load. Initially, in the intact joint in the female, the lateral bending contributed a bit more than the nutation counter nutation to off-axis loads during axial rotation. But in the dysfunctional joint, there was now a bit more nutation counter nutation being applied during axial rotation. This you would see between the blue box and the orange box, and that asymmetry sort of flipped to become more nutation counter nutation dominant. So just to summarize where we are at now, it's what is normal for us from our study is telling us that male and female have similar mobility. Axial rotation is greater than nutation and counter nutation, and male and female joints are asymmetric, such that counter nutation and FC lateral bending are the predominant motions. But in the dysfunctional joint, the mobility of the female joint surpasses significantly that of the male joint, and nutation surpasses significantly the axial rotation, and male asymmetric motions become symmetric, but without hypermobility. And while the female asymmetric motions become hypermobile, and they also add on more asymmetry. In summary of all of this, what we did find is that asymmetry really points to the opening of the anterior pelvis. And it begs the question, if the opening of the anterior pelvis may be necessary for childbirth in the female joint, is it dysfunctional all the time, or could that also be a way to assess dysfunction even postpartum, or in a person who is not at the point of pregnancy or parturition? So taking what stage at this point is that the secondary ligaments play a large role in the sacroiliac joint dysfunction, and dysfunction in females does look different than in males. The treatment of the intact joint looks different than dysfunctional joint, but we will get into how do we optimize treatment subsequently. And finally, the intact condition of most cadaver biomechanical studies up to this point have been incorrect. That doesn't mean that their end results are incorrect, just that the intact states were not truly intact because the secondary ligaments were resected. One point as well is that if we see that in the male joint, it may not be a mobility issue. could it also be a degenerative issue? And this is why we think about it may still be necessary to fix a ligament when a joint which still has an intact ligamentous complex sometimes. So for the intact axis of rotation, we wanted to go with axial rotation first because in an intact joint, that was the predominant motion. And this were the axes in contraaxial and ipsiaxial rotation. And we know that that differs between directions as well. But for simplicity, we would take the mean in a simplified model just to see where they intersect. In the male joint, the axis rotation was really at the anterior portion of the sacral ala. And in the female joint, it was pretty much in the middle of it. And the lines on the right images shows where those axes cross the joint in the mean axis. To fix this, we go on two principles, which are we want to be as far away from the axis of rotation or from the center of rotation, but we want to be also as far away from the axis of rotation. By being far away from the center of rotation means being as is the linear distance. So for example, in the male and female joint, you can tell that the posterior region of the joint is farthest away from the centers of rotation when you are looking down axially. And when you look sagittally, what we consider to be being far away is not a matter of linear distance, but a matter of angular distance, in that you want to be perpendicular to the axis of rotation. So the arrows that we show are perpendicular to the axis of rotation and telling you what direction should you go into the joint in order to stabilize an axial rotation. And this would really be it could be mediolateral, or it could as well be anterior posterior, because those two axes are perpendicular to the superior inferior axis of axial rotation. The endpoint for this is that in both the male and female joint, the posterior aspect of the joint is most mobile and gives you the best opportunity for rigid fixation for fusion. In the male joint as well, you could also fix the middle portion of the joint. In the female joint as well, the anterior portion of the joint could be fixed. And from there, we'd go into the dysfunctional axis of connutation, continuation. Just as Dr. Kurosawa found in his model as well, we see that the axes are sort of oblique as well, whereby it's not really perfectly straight through the joint. And so when you walk, nutation on one side, it does lead to counternutation on the other. Just for simplicity, we try to show as well the intact axis of rotation. And the intact axis of rotation is really close to the interosseous region. And this may be important for study for techniques that aim to restore fixation at that point, would place in the intact axis of rotation, which is marked by the I mark. But upon dysfunction, the axis of rotation shifted, or the center of rotation shifted, and they shifted differently in the male than in the female. In the male, they shifted anteriorly. In the female, they shifted inferiorly into the joint. To fix this as well, we did recommend the posterior aspect in the male joint was the farthest from the joint, up here, down here, and in the female, the superior aspect was the farthest from the nutation, counternutation axis. We do plot some lines or trajectories in a way that tries to hit all points that are farther away from the axis of rotation. But we do think that all you need is really the farthest location at the end of the day, which should be the superior aspect in the female and the inferior posterior aspect in the male. For the trajectories that this tells us to use would be something more along the line of a trajectory that lays along the sagittal plane, such as an anterior posterior or a superior inferior trajectory. But pure superior inferior trajectories are not possible to use, just given the understanding the nature of access to the joint. Um, just least importantly was lateral bending, which was still was hypermobile. What we did see in lateral bending was it really crossed the entire joint surface when in its axes, and you can see that clearly from the right images, where we show the trajectory of the lateral bending axes. In the male, it is sort of inferior, and in the female, it is more in superior, sort of crossing the interosseous region, while in the male, it's more crossing the articular region of the joint. And to fix this, you could go superior, inferior, or lateral, but it also changes differently in the male and in the female joint, whereby in the female, it is the farthest point away from the center of rotation is inferior, and in the male, the farthest point away from the center of rotation is superior. And we show some possible trajectories to fix, which would maybe difficult in some cases, and in other cases not too difficult. To summarize all of this and thinking about the optimal fixation points, we try to grade the points based on how far was each point from different sort of motions. What we found was that the posterior inferior region of the joint was the most mobile region in a dysfunctional joint. And it did present the greatest opportunity for fixation, especially in the male joint. However, in the female joints, we also saw that in addition to the posterior inferior region, the superior region of the joint too would recommend that should be included when fixing the female joint as well. And if you'd want to hit all three in the female joint, the anterior aspect was also important. But in the male, we didn't really find the anterior aspect of the joint to be really important for fixation. And this would be because it was pretty close to the centers of rotation, whereby the largest forces on the male joints were pretty much applied anteriorly. And so fixation anterior would likely lead to loosening of that implant if it was placed that deep. And the anterior aspect of the joint is not also easily accessible for posterior techniques. In the female, as I said, the superior and the posterior inferior regions could be fixed, but we sort of provide a gradient for what fixation at each plane would help you stabilize. In optimal fixation trajectories, we do try to map out the axes and recommend trajectories to use in order to stabilize each axis if you're going at perpendicular to them. And for the most part, nutation, counter-nutation, and axial rotation are pretty straightforward. It's only lateral bending in the males that is not perfectly aligned to an anatomical plane, in that it is sort of tilted when it rotates in lateral bending. For using a fixation trajectory to fix the joint, it is really recommended that you use a device that has a well-defined principal axis, such as a screw, a threaded cage, or a long device, whereby you can tell that this is the principal axis of that device, and then you can aim that axis to be perpendicular to the axis of rotation of that joint. And finally, when we try to combine all of this together to see what would be optimal in fixing the joint while targeting the best points for fixation, as well as aiming in the best trajectories for fixation, or for the most mobile planes. We saw that the anterior posterior axis would be most effective to prioritize nutation and counter-nutation and axial rotation as well. And that in placement of the implants, we would need maybe 2 implants, one next to the S1 pedicle and the other next to the S1 facet. Now, what we did see was that these trajectories almost, this recommended technique really was similar to that published by Wise and Dahl in the early 2000s, that went through the PSIS and into the interarticular portion of the joint. However, these are still just trajectories, and in single implant systems, we believe that the optimal point of fixation is really the posterior inferior region of the joint if fixation is what is intended. And we believe that if restoration is what is intended, then the interosseous region of the joint would be the best location for stabilization of the sacroiliac joint between the male and the female. Thank you very much.
Wow, thank you very much for this really interesting talk about the anatomy, about function, and about recommendations for us as surgeons to think about what to use where and when.